Meeting to order 1 minute late, my apologies. Oh, 2 minutes late, my apologies. We have a quorum, and I believe Dr. Malone will be coming soon. There's already been some comments about the length of the agenda. I will explain again. The agenda has anything and everything on it that we might possibly want to talk about, since we can't talk about it if it's not on the agenda. Thank you, lawyers. So, start out with, here's a guess. I've already done the roll call. Bring everyone's attention to the vision and the mission. The vision is a unified, comprehensive, and effective EMS trauma system for a healthy, safe Texas. The mission is to promote, develop, and maintain a comprehensive EMS trauma system that will meet the needs of all patients and that will raise the standards for community health care by implementing innovative techniques and systems for the delivery of emergency care for the entire population. Before we jump into the agenda, there are two things I am going to talk about that aren't on the agenda. One is that we've had 3 members who reapplied and were confirmed to stay on the committee. And if I get this right, it was myself, Dr. Jarvis, and Dr. Malone. Also, this will be my last meeting to chair this committee, effective in February. Dr. Beeson has stepped forward to chair this committee. I thought that was appropriate for a couple of reasons. One is I'm now the vice chair of the council itself, and second of all, Dr. Beeson is the EMS medical director representative to the council, and to me that means he should be the chair of this committee. And unofficially, I just think it's better for him to do it than me. So thank you, Dr. Beeson.
Thank you so much.
You are welcome. As we continue to go through the agenda, I would like to ask, I don't know how many people printed out the materials or have them on guidebook on your electronic device. We are going to talk about the policy statement, transfer of patient care between EMS providers and receiving facilities. If you can make sure you have that out available and maybe have looked at it. Aside from that, I am going to jump in to the agenda. Item number 1, this was put on the agenda, and quite frankly, I forgot about it till last night, is identify and list accomplishments of this committee since its inception and report back to the council. I am not going to try to do that right now. We will go back into the web and look at the policy statements, position statements we've put forward, and I would ask for people to submit to me what you remember as accomplishments. Is that all right with everyone?
Yeah.
Is that okay? And then we will fully disclose those at the next meeting. Dr. Perk, would you like to go? Would you like to present?
I'll be happy to.
I go out of order in a big bad way.
Okay.
And again, I do go out of order on the agenda because, like I said, we put everything on the agenda so that if we want to talk about it, we can. Your item number is actually 20, although number 3 came from the Cardiac Care Committee. Are you still on that committee?
I am, but I am.
Do you know, we talked about this last time, that number 3 is considered STEMI as a reportable disease.
And also number 15 is the reason for it.
And 15 is the reason? You got 3 items. I'm just telling you.
I'm glad I came so well prepared. Yeah, that's excellent.
So
yes, we wish you would consider promoting STEMI as a reportable disease. And part of it, the reason for that is that it kind of goes to a number of things. One is that EMS brings STEMI patients to the hospital, and a lot of hospitals give us feedback on it. A lot of hospitals don't. A lot of patients we bring to the hospital that we don't think are STEMIs turn out they're STEMIs. We missed it. We really don't have a good grasp. And aside from that, just in the state of Texas, as we talk with cardiologists, what is the incidence and prevalence of STEMI in the state? And everybody's making pretty educated guesses, but we really don't know. If it were a reportable illness, that would force, and there are many illnesses that hospitals routinely report to the local public health offices anyway, so we're not creating a process. We would just be adding another disease entity to that list.
So what is it we need to do as a committee?
So that would require a rule change somewhere. I don't know how the government works well enough, but
none of us do. That's not bad.
But that would require something in some sort of statute. So, for example, like syphilis and HIV and tuberculosis are reportable illnesses. When hospitals come across those illnesses, they report them to local public health, and then public health does contact tracing, so on and so forth. Contact tracing obviously wouldn't be an issue with STEMI, but nevertheless, we would have a much more accurate idea of the both the incidence and prevalence of STEMI in the state of Texas.
Okay.
And then that could feed into all of the other, cardiovascular health initiatives.
Is there a downside?
The downside, I would think, would just be that, for hospitals, that would be another thing they would have to report, so there'd be some manpower issues there.
Okay. And then what about I don't know if there's anybody here that knows about the cardiovascular, we talked about it last time. It's a cardiovascular council of some sort.
Yeah.
Yes. Do they? Yes. Do they, what's their stand on this, or have they taken a stand, or?
I would suspect that they would be in favor, but I can't speak for them.
Okay. So as a committee, what do we need to do? Do you have any request or direction for us besides to say it's okay with us?
Well, it probably needs to be moved up through to the main GETAC.
To the council?
Yeah. And then moved on to DSHS from there. It would be a different arm of DSHS. It won't be the EMS branch. It would be a different branch of DSHS that I would think would need to, or maybe we could put it in our rules. I just don't know.
Does the cardiac committee already have verbiage or a plan or process in place?
I don't think so. I think they want to reach out to other committees and probably come up with something. That'd be a good question for Dr. Smalling.
So if we made a motion that we would be supportive of cardiac care committee promotion, movement of making the ST segment elevation MI a reportable disease, would that work?
I think that would be a move in the right direction, and we would appreciate that effort on your
Was
part.
that a motion?
That was a motion.
So our motion is to support the cardiac care committee?
Good question.
Was that?
No question.
Okay.
I'm not sure. Do you know, sir, is ST segment elevation MI ICD-9 or an ICD-10 diagnosis?
Yes.
I think the diagnosis is just MI.
Well, I don't know. They get to be pretty well defined. Now, certainly, cardiac cath intervention, which is a billable issue,
Yeah.
would be codable somehow.
I'm just wondering if it would be more effective to just make it, rather than STEMI, would it still be effective if it was just MI reporting?
So
I think
hence-
what they're really driving at is when you have a patient who needs a cardiac cath intervention.
So if I understand this, the reason from our perspective is to facilitate us getting feedback on these patients.
Well, that's what's in it for EMS. What's in it for the cardiovascular community is a better idea of how big the problem is, and maybe some better identification of where these cases are occurring and what types of patients they're occurring to, so we can then start doing some preventative health measures.
This is an initial step for registry development or participation on a statewide level. All the things that we're doing on a regional basis, this is an
Right.
attempt to get it to a statewide piece. Hence the reason we would be supportive of those endeavors, and the cardiac committee can work out a few more of the details.
Right. Pretty much every RAC has got a cardiac care committee, and they're trying to track the STEMIs that are brought in by EMS or local hospitals, and I think we all think this way, but in my RAC, I think we got pretty decent reporting, but we've had trouble. We've had hospitals that just, not due to non-compliance issues, they just were, they were having a hard time getting their arms around it.
Sir, I think it's a great idea. I was just looking. It's an ICD-10 diagnosis, but not an ICD-9 diagnosis. And I just don't want us to think that the coders won't be able to fulfill. But if we can think another way around it, that'd be awesome.
So what about the intervention?
I mean, certainly the intervention
Yeah.
could be reported.
I thought it was an ICD-9. Because
No, it's just
Well, we put it in.
myocardial infarction.
But I think there's acute MI with and without intervention, and all, there's like too much stuff.
And I think we would probably want a broader,
Anterior, inferior, blah, blah, yeah.
I think we'd probably want it broader than just whether they get intervention or not, because what we want to find out, again, completely selfishly speaking here, is did we identify the patient? If it turns out that we identified the patient appropriately and they didn't go to cath lab for any number of very valid reasons, we would still want to capture that. So I think it might make more sense if we were really tried to stick with the STEMI, the disease diagnosis, as opposed to the intervention.
You're right, because a lot of patients who are having STEMI have contraindications going to the cath lab.
And as you pointed out before, some of those contraindications are not necessarily contraindications we feel are contraindications.
That would be true.
Okay, so we have a motion and a second to support the Cardiac Cares Committee's actions to make STEMI a reportable disease. Anyone opposed? We will consider that passed. Thank you for presenting that topic you didn't know you were going to present. Would you like to now present the topic that you were going to present, which is, hold on,
You said there were 3. Is there another one that I'm...
somebody else threw you under that bus.
that I'm so prepared to present?
Actually, the thing that I was going to report on, I'll need your help.
All right, well, I'll stay for that.
Yeah,
Okay.
so the next item is number 20, the Medical Practice Act, boy, that was bad. Dishes Administrative Code rules and the gap between them.
Yeah.
And I believe there is a PowerPoint presentation.
So first of all, let me thank the committee for allowing me to come and Chairperson Greenberg for giving me this opportunity. I see that there's a gap between chapters 197 and 157. I've got a couple slides here to sort of illustrate that. I'll be reciting some things which you already know by heart, so bear with me. So let me just get into it, and then we can just talk about possible solutions. So we're all familiar with the Medical Practice Act and the EMS rules that apply. And draw your attention to 197.3 for offline medical director, where in that it states that the purpose of this chapter is to facilitate the use of our skills as physicians with EMS personnel, and that they'll be consistent with the patient's health and welfare, and a person using our supervisory guidelines and the skills of both the physicians and the EMS personnel. But I want to draw your attention to a very important word in there, and that is delegate. So reminding everyone that Texas is the last state where we still operate off of delegated care. And pursuant to that, it also says that nothing in this chapter shall be construed to relieve the supervising physician of the professional or legal responsibility for the care and treatment of his or her patients. A physician who, after agreeing to supervise EMS personnel, fails to do so adequately and properly may be subject to disciplinary action pursuant to the Medical Practice Act. So we're held to the same standard as if the patient was right in front of us. We all know that. But there is a clause that reads that a medical director should not be held responsible for non-compliance with this chapter if the EMS administration fails to provide the necessary administrative support to permit compliance with the provisions of this chapter. And while I think that's a very good thing, and I would never suggest that that be changed, I think that was part of the problem. Further on, it says, in order to minimize the problem that I'm sort of painting the picture of, it says that we are responsible to develop a letter or agreement or a contract with the medical director and the EMS administration outlining the specific responsibilities and authorities of each. The agreement should describe the process, and then it kind of goes into to describe the process by which the medical director may withdraw responsibility for EMS personnel for noncompliance. Well, that's kind of specific to an individual provider. It doesn't talk about the system. And I think when this was written, they were concerned more about the physician to the individual EMT and or paramedic. They weren't really thinking about the EMS agency as an issue. Now, over on the rules that apply to the EMS providers, and that's Chapter 157 and Subchapter B about the provider licenses, it says that there's a declaration of an employed medical director and a copy of a signed contractor agreement. This refers to 197. Who's currently licensed in good standing with Texas Medical Board and all these other chapters. An interesting word is in there. It's employed. So if you're employed, there is a rank structure, a power structure, there's a structure there, a relationship that is implied by the word employed. So the problem is what I call powerless accountability. Now, Ken Miller is an author, and he writes a lot of books about governance and how governance should work and how governance sometimes doesn't work the way it should. And he talks about, and this is a quote from one of his books, says, powerless accountability is a recipe for disaster. And I think that that's pretty much speaks for itself. I also think that that's the situation that we sometimes find ourselves in as EMS medical directors. So where does the power lie? And I would suggest that power lies in two places, really. One is, and we're familiar with this, it lies in the credentialing. You get to say, based on 197, which individuals can work on your license and which ones can't. So credentialing clearly is power. But when it comes to system oversight and QA and things and education, well, those are all budget issues, which generally we don't have any control over. And so then the question, the way I see it, is when it comes to us being held responsible, well, if the provider agency doesn't provide the EMS medical director the tools to meet the requirements of the law, then who is responsible? It says you're responsible, You're responsible, you're responsible. Except in this situation when you're not responsible. And then it's silent on who becomes responsible at that point. And I would suggest that there are EMS provider agencies across the state, medical directors, who find themselves in a situation where they want to do the right job, they want to follow the law, and they want to be very responsible and conscientious, but the EMS provider agency doesn't give them the tools to do it. The provider agency responds by saying, you don't need to worry about it, your own law resolves you of any responsibility. And so then in that case, who's looking out for the public? The public is left without anybody really by law responsible for what happens to them. The medical director is not responsible because the provider agency didn't give them the resources. The provider agency doesn't assume that responsibility because it doesn't say that it does anywhere in the law. So what are our solutions? And I will just suggest to you that I thought a very good solution that came up, and we'll tell you what, why don't I just throw this out, and when we have a little bit of a discussion about what it is, then I'll tell you about one proposed solution which may be helpful, but I don't think it really covers everything. So there's the problem. I'm willing to take questions.
Any questions for Dr. Peirce before he gives us a potential solution?
I can remember when the Board of Medical Examiners basically wanted some of the people that are here to help them with the words of how those online and offline positions were to be fulfilled, and all those various jobs that you were responsible for. And at no time did we ever shirk that responsibility. We always said, sure, I mean, we should be the ones signing off on these medics once they're ready to practice, and they should be delegated under our practice. So we didn't go away from the responsibility, but I feel it, same as you do, that I don't have a lot of control over the ambulances we buy, or the tires we use, or the doors we have on the ambulances. I mean, that's not my, I don't allow that.
Well, I worry about things like, who's intubating, how successful are they? Those that are not as terribly successful, do I even know who they are? And then do I have an ability to remediate them? And if after they fail remediation, maybe then I need to consider taking away their privileges, but I can't even measure the problem right now if I don't have the resources to do it.
Dave, I think the issue is who falls under what rule or law. Obviously under 197 it's a physician, but if it's not us, 157 doesn't cover that. 157 can't hold the physician responsible because they're what, and it's vice versa. The medical board can't push back on dishes. It also says in 197 that the physician is responsible for all aspects of the operation of the EMS that affect clinical care. And that could easily go down to the ambulances that are chosen, the monitors, the staffing, and everything else. And so you're right, it's a finger pointing back and forth. I think the one statement that we can't be held responsible is trying to protect our license when we say this is what we want done and the operator or the provider doesn't do that. But you're exactly right. Then who is responsible?
Well, if it didn't have that clause, every one of us would be a darn fool to take the job.
You're exactly right.
So that can't be changed.
No.
But I guess the question is, this is why I'm going through this body, is I think that the opportunity for improvement here lies more over in 157 than in 197.
Yes.
Yeah, I always used to think there was a great clause that we wouldn't be held responsible, but I think unfortunately it's kind of given all of us an out.
Well, and and the other thing is, from my standpoint, I sometimes think about what we could refer to as the ghost medical director. The person who shows up once a year to sign the protocols and pick up a check. They can do that. They can be that way because of this.
Right.
And that's not good for the public either.
Right.
That's
So
great for the provider agency. They got a doctor and they're not in their hair.
Yeah, what's your recommendation, sir?
So the recommendation is not my recommendation. This is actually somebody who's much smarter than I. The recommendation was that we come up with a draft agreement between the medical director and the provider agency. Because right now, I know in some provider agencies, they will only sign the agreement which basically repeats all of the other things in 197.3b, which is the responsibilities of the offline medical director, of which there are 17. One of them goes to education, but the remaining 16 sort of lay out, and they're really pretty much refer to credentialing. And so those things are in the letter, and the provider agency, because they have to, will sign that, but they will sign, if there's anything more in it, they won't sign it. And so the thought was that we create a draft letter that puts in things about QA and education and the financial support required for those, and that those will be made available to the medical director so that they can be compliant. And potentially even put in there that in the event that they don't, name somebody who's then responsible for the clinical care, who assumes the medical legal responsibility, although I'm not a lawyer, that may not be possible. But if you're going to say the physician is no longer responsible for the advanced life support and basic life support that's provided, somebody needs to become responsible for that, one way or another. And again, I'm not a lawyer, so I don't know if any of that would be binding, but one suggestion was to come up with a draft letter, and then it would have to somehow be put into a form such that while not mandated that that letter be used, it was at least sufficiently strongly suggestive that if somebody, a provider agency, refused to sign that letter, that, and then a case comes down the road, that the medical director could defend themselves, say, look, here's the draft letter, this is the thing that was put together by GETAC through DSHS, through a community, an EMS community process that covered all of these issues, and the provider agency refused to sign it. I was left signing what is now signed, and now we've got this bad outcome, and I'm in front of a jury. And so, it's holding people responsible for what they should be held responsible for. That was one suggestion. The other suggestion was actually to somehow put into 157 something that more explicitly says that the provider agency director then becomes personally responsible. We are held personally responsible. If we're going to be relieved of that responsibility, I would suggest that not an agency, but an individual be made personally responsible. Because that puts a whole lot more oomph behind it. Anyways, I don't know that either of those are palatable, but they are suggestions.
When they were originally putting it together, 197 said the medical director, in conjunction with committees and boards, and they listed a whole bunch of people that would be responsible for those protocols. And the one thing we did was say, no, you can't have all of the, how do you sue a committee?
Right.
And the committee's always moving and changing. Why don't we just have the medical director as the responsible party?
Right.
So the Board of Medical Examiners, I think, sees it that way. If we're going to be the responsible...
Use the microphone, sir.
Oh. So if they see us that way, if they see us as the responsible party for the Board of Medical Examiners, we just have to make sure that the Department of Health supports that and that there's a give and take in that process. If I'm going to be responsible for every medic, then they have to supply those quality reviews that are required for me to be comfortable in being responsible for those guys.
So you've made two recommendations. We should probably talk about those and see if we want to pick one or if we think both are viable. One is and what I see it as is like a template. We have templates for first responder agreements, mutual aid agreements, a template for a medical director agreement. It would not be mandatory, but it would be encouraged. Or a change in the rule to define quality assurance, all of the things we need.
When we went and met with the board about 197, one of the discussions was changing 157 to add that the provider's responsibility is to show evidence that the medical director is doing. They can't make the medical director do those things, but the provider, through dishes, has to show evidence of maybe these things that we're talking about in the agreement. And maybe the evidence is an agreement that covers these things specifically that are in rule.
So in 157 today, it does put on there's a burden put onto the provider agency that they do quality assurance. If I remember correctly, there is a single line that says that, and there's no definition of what quality assurance means for the provider agency. And so that could be anything from, preventive maintenance on the vehicles, I don't know. But there's really little definition to it, if I remember correctly.
There's actually 4 requirements that talk about patient care, preventive maintenance, complaint management. I can't think of them off the top of my head. A minimum, those things have to be addressed.
Yeah. 197 also.
So I would think, David, at this stage, it's probably worthwhile additional study. I don't know the mechanism that we could do that from this committee, but probably both options are worth looking into further and not negating one or the other. I think there are some probably potential unintended consequences. I think there are probably some agencies who may welcome the opportunity to take that responsibility, whether good or bad, that they would less involvement with the medical director may be an option.
Well, that's why an individual needs to be named.
Right, and so then
An
that
individual
alternative with
power.
157 making that would be
Right.
palatable. But I think, again, it's interesting concepts and a complex thing to answer, but worthwhile for additional discussion and see what venues come out of this. But I think it's definitely worth additional inquiry and discussion to figure out what the right solution might be.
Dr. Manifold, as you say that, I probably need you made me think about something, is that you're right, there may be some individuals who would feel comfortable taking that on, probably not knowing what they are doing or what that means really. And so maybe that's not a good suggestion.
Yeah.
Again, there may be ways to again look at the wording or the process to do that. If we don't make it mandatory, though, I'm a little concerned of how effective it would be. That's just a personal aside for that.
Maybe
Again, that's why I think it needs additional discussion.
I just want to say thank you for bringing this to our attention in terms of the gap that is there. And I definitely like the idea of creating a template that could be potentially used to confer with the agencies about responsibility and where the requirements are. But I wonder about designating someone from an agency who's not an actual medical provider. So if you're not licensed in the state, I wonder about medical legally if that person is even able to take on responsibility for the care that's out in the field. And so it might need to be more based on quality assurance or ensuring that whatever is in place for an EMS medical director to oversee or delegate that care, as opposed to working the other way of choosing another individual.
Yeah, I think you're actually right. Another reason to probably throw out my second suggestion, because you can't give a non-physician physician responsibility. That was a really bad suggestion on my part. The more I think about it, so thank you for enlightening me.
But the administrator of record has a tremendous amount of responsibility for the agency and a legal obligation. They can't be responsible for the true medical care, but they're in the fulfillment of the intent of what we're doing in this world with caring for a patient, delivering them to a healthcare system or alternative site. And, there's a tremendous amount of responsibility that they have, and there may be some opportunities for shared responsibility. It's never going to go away from the medical director for the actual patient care piece, but that's what we're trying to fix, right?
So motion, we take this topic to the council to see who they would like to, other committees or whatever, to discuss, or create a group to discuss this issue. Is that appropriate?
Is there a second?
Yeah, I would. Oh, is that a?
I move this committee send this to the council.
Go to the council, yeah. This would have to take this, EMS committee, some of the other committees would want to weigh in on this. We can send our recommendation for whether we want a template or a rule change, although we should probably send consideration of both. We need is there a second to the motion? Second? Spears, second. Okay. Further discussion, including Dr. Perkins?
Well, my only thought was, maybe I'm not familiar with this, is in order to get the other committees involved, you need to go to council. Is that what you're saying?
Yes.
Okay.
We can make a recommendation for either what we think is a solution, but it needs to go through all the committees and back to council. Needs to look at it, figure out which committee should be involved, and have it come back to council. And again, sometimes the state hears things like this, and regardless of whether we take action or not, they may take action. Not a bad thing, necessarily.
I think the important thing, well, it's important that this issue get raised. I think it's the elephant in the room in EMS and nobody wants to talk about it. And we need to talk about it.
Does anybody know of anybody that has been disciplined by the Board of Medical Examiners for deficiency in offline or online medical control?
Just had our first one last quarter. There was actually a physician named with discipline for EMS medical. So they're actually doing it now.
Okay.
And while I completely appreciate your point, I would suggest that my real push behind this is that when this occurs, it's the public that's left vulnerable.
Yeah.
And that's what's kind of got a thorn in my paw. And I think that's the thorn that should be in everybody's paw.
So before we go to council with this suggestion of this type, do we need I'm just looking at a refinement of what we're proposing or asking. So we need an internal working group or subcommittee to refine this a little bit more before we move forward?
I'd recommend we do both, just because the amount of time it takes to get anything through. We can continue to work on this and send it to council at the same time. So were you volunteering to be on said work group?
You looking at Dr. Purse? Right?
No.
I would be happy to assist.
All right. Anyone else would like to assist Dr. Manifold, including non-committee members, if they're
Can I
available?
volunteer for that?
You have. All right. So Doctors Purse, Manifold, and Greenberg raised his hand.
And I'll help.
Oh, and Dr. Jarvis? That sounds like a good work group. And,
Well, I'll be anyway.
yes, Beeson will be the chair soon. So.
So that document would not try to change anything that the Board of Medical Examiner,
No.
their rules are set. So this would just be a way to use those rules to make an agreement between the service and the medical director that makes sense.
Right. It would, so that both 157, 197 talk about there being an agreement. And so, but that's, but how that's crafted is left up to the individuals. And so this would be at least a template, if nothing else, or maybe a guideline that all of these things must be addressed. Maybe we do it that way. All of these things need to be addressed in the agreement.
David, do you think we're in a unique position because of the delegated practice we have here, that we're
Yes.
in this situation? So no other states or processes to best practices to help us out?
I would say that no other states have
It gets a little.
they've completely skirted this issue, the other states.
The offline is pretty clear, it's whoever signatures on the protocol, but the online can vary by week, date, night, whatever.
Right.
So that'd be a little harder to define for the public.
But this is really the meat of this, is the interaction of the medical director with the EMS agency.
Yeah.
Right.
Well, 197 even clarifies that the offline is to have agreements with those providing online. So that's kind of in 197 already.
Thank you. That was all I had on that issue.
Okay.
One last question. You said that we were the last delegated practice state?
Well, that's my understanding. I don't think any of the other states truly have delegated practice. I had heard at one point that someplace with an M, Montana, Michigan, Minnesota, someplace, but I don't know that that's true.
Huh. Somehow I didn't think we were that unique.
And Dr. Moore, you had, which
Number-
topic is it
number
that?
15, treatment options for cyanide poisoning.
Okay.
And I got a call from a gentleman that wanted me to look at other options and then referenced some work that Dr. Purse had done. And sure enough, in the last, I think I sent everybody around the abstracts on a study that Dr. Purse did there in Houston. 50% improvement in their survival in some cases with people that were a combination of carbon dioxide and cyanide poison. What we're doing with the Lilly kit is actually making a lot of patients much worse. And I really brought this so that this is information we can disseminate, just so that more people would know what choices they need to make. Some people might want to stay with the sodium thiosulfate as the only option they use, but if they want to go with hydroxycobalamin, which has the better success rate, they're going to have to invest some dollars at some point, because the treatment is probably, what, $1,000?
800, yeah.
800 per ampule. But, I mean, it's a man's life. And I was just going to hope you could tell us a little bit what happened in Houston when you used it.
So we've got, what you have in front of you is an abstract from basically it's a case series. And we had a number of remarkable saves. The first time we used it actually was on an active duty firefighter who went into a house, and it was a single story wood frame structure where it seemed like it was going to be a routine fire. He must not have got his air regulator into his mask securely, because in the darkness in the house he bumped into a fellow firefighter and the regulator fell out of his mask. He gave a 2-word expletive and collapsed on the floor after having inhaled 1 breath of air. Then, of course, as you can imagine, there were difficulties getting him out of the building. A mayday was called, and they got him out into the driveway. He was pulseless and apneic. They initially started CPR, got him into an ambulance. The ambulance was right nearby. The medic was on the other side of the fire, so it took a little while before they got the hydroxycobalamin, and actually it wasn't administered until they were almost at the hospital. But halfway through the first bottle, he started moving his fingertips.
VFib or something?
He didn't get monitored because he was in a BLS ambulance, and so they brought the cobellum in, but they didn't have a 12-lead, so we didn't have a rhythm on him until he arrived at the hospital, and at that point he had a neurologic function and was in a sinus rhythm. We then had a second firefighter some months later. It was the second crew into the home. The fire was in the back of the home. A flashover occurred in the front room. Everybody ran out the front door. They quickly did a head count, came up one short, went back into the home. The front door led into the living room. The kitchen was off to the right. They found him in the kitchen. His helmet was off, his mask was off, and his gloves were off. They pulled him out. He had severe burns to his face, his head, his hands, and was apneic compulsus. They began CPR. They got him on the monitor, and he was in asystole. And he remained in asystole until partway through the first bottle of cyanocobalamin, when he spontaneously started a rhythm, and a few moments later he started moving his fingers as well. We have two cases. There were New Year's Eve fire, 3 children in a home. 2 of the 3 children were brought out in respiratory arrest with weak pulses, bradycardic pulses. They were both administered as cyanocobalamin, and they were awake by the time they got to the hospital. We also have cases of folks where it was used where it didn't have any response. But when you kind of look at the details of those cases, you can sort of see why maybe it didn't. For example, there was a case of an elder woman whose house caught on fire. It was a kitchen fire, and she was found on the floor in the kitchen. The stove, whatever she was cooking on the stove, had gotten hot and somehow set something on fire in the home. So she could have been on the floor from cardiac arrest for a long time, and she was not resuscitated in spite of the hydroxycobalamin. And most of the cases where it didn't work, there appears to have been a pretty long gap between when the patient probably collapsed and when they got the hydroxycobalamin. The cases where it worked rather miraculously, the ones that I've described, there was a relatively short interval. But certainly the 2 cases of the firefighters, who, by the way, are both back to work and both have children and are both back to work, they were treated pretty quickly. The 2 children, fortunately, they were only in respiratory arrest. They had Glasgow of 3 and were respiratory arrest, but with pulses. They were found in the back of the house, so it was late in the primary search, so they were probably exposed longer. But those kids are back in school and doing well and have survived their burns. One kid came out, was still conscious, did not get the hydroxycobalamin. The other 2 children did, and some of them, they got severe burns, so they were in a high heat environment as well, and they returned to basically normal lifestyle with scars.
So as I understand it, the usual Lilly kit has the sodium nitrite, and you're basically creating a methemoglobinemia, which is competing for whatever
oxygen is available
left, and so that makes them worse unless you can reverse it with some other method.
That's right.
So we're actually potentially hurting people with that.
Right. The old Lilly kit in a mixed gas environment with the carbon monoxide present actually can make the hypoxia worse. And the hydroxycobalamin works a different mechanism. It goes into the mitochondria and works there.
It just binds to the cyanide, creating a neutral compound.
Yeah.
I believe there are some AAP guidelines on treatment of cyanide poisoning in children that came out years ago, and it does recommend only hydroxycobalamin for that exact reason, because the methemoglobinemia can be so severe that the outcome is far worse for kids.
Well, the only downside that I see with hydroxycobalamin, in addition to its cost, is that it has a relatively short shelf life. It's 36 months from the date of manufacture. Now it's a lyophilized, it's a powder. It's got to be reconstituted. So I'm not really certain. I have no idea why it's such a short shelf life. It would seem to me that it should be a much longer shelf life. But that's at the manufacturer. Maybe they've only tested it out to 36 months and never tested it beyond that. But it's just most likely.
Good and through. Guaranteed good through. So what?
I just think we need to get this information to our medical directors through whatever method we can, dishes or whoever, maybe an article that would say you have limited choices when there's carbon monoxide involved, that you should use the Lilly kit. Your primary kit should be the newer Sino kit, which is more expensive, but in some systems I know that maybe they'll have supervisors that only those trucks have it available and not in every ambulance or whatever.
Yeah. We always joke about what is the value of a life. We don't joke about it, but that becomes part of an argument. Well, I'll tell you in Houston, I don't foresee the day when we're not carrying it in our system. Now, we don't have it on every medic unit. We have it on our district chief vehicles. There's 20 of those, or we've got 40 BLS. So we figured out a way to reduce our overhead, yet it's on scene at every fire. So every system probably needs to think through how to use it most efficiently, or to have it, to have it in a way that doesn't break your back financially. But our stories, I think, are pretty dramatic.
So in regards to having some action from this committee, can we do you have something that could be published or publishable by the state in what they're sending out a newsletter now, and instead of the Texas EMS magazine? And we could make a recommendation that this topic be presented at next year's Texas EMS conference, but that's a year away.
Maybe the abstract. I wouldn't.
Got passed out.
Right.
But we don't want to advertise for there's only one manufacturer of this.
Oh, yeah, I want to say,
Right.
I
It's not
have
generic,
no
so-
financial connection with
Right.
the
Yeah,
people
yeah,
who
yeah.
makes this stuff.
So, I mean, the recommendation we can make is that the state disseminate this information as widely as possible. I mean, I'm looking for something we can do. I think
It just kind of scared me.
my impression is everybody's in agreement.
I'm at a level 1 trauma center. I went to the pharmacy. I said, do you have any cyanocobalamin? And they said, huh? And I explained to them what it's really used for. And they said, well, we can't get the cyno kits anymore. We can't get the Lilly kits anymore. But we haven't ordered anything else because we didn't know there was anything else to order.
Right.
And this is a good guy. He's a really responsible person. He just didn't know. So if we have people in our state that don't know when it's confined space exposure to do the newer stuff, then what
Well,
can we do?
the other thing that it was on the news the other night, some national fire organization came out and was able to show how, because of construction and the materials in homes today compared to, 20 years ago, that they burn 8 times faster and 8 times hotter. So that's a it could perhaps be, maybe our fire colleagues will know what I'm referring to, because I just saw it in the evening news, but it was some national organization had done some sort of a scientific study, and they were able to show that it's an 8-time greater rate of growth and the heat of the fire. And so that puts, certainly the firefighters at increased risk, but those family members, and this was the point of the story, is that they were really pushing smoke detectors, because you don't have the time maybe that we did 20 years ago to get out of a house if you waited for, either to get loud or to get bright or whatever. People today just don't have that kind of time because the fires grow so more rapidly. So we're actually in an environment where we're at greater risk of people having these combined exposures, and therefore the responding agencies need to be better prepared to treat those patients, because it can work. It absolutely can work.
So I make a motion that we forward the information on to the state for dissemination, in addition to we post information on the medical director's site with Dr. Purse's protocol that he's so nicely going to share with us, and if others have protocols that we can also suggested protocols that we can put up.
Thanks for letting me put you on the spot.
No, it's,
So we had a second to
I'm
that.
here to serve, Dr. Moore.
I already stole it, so thank you for providing it for the steelage.
Sure.
Is it just from the HFD side, or can you send that to me so I can get it to the state?
Yeah.
Oh, well, once this motion passes, of course,
If it passes.
if it passes. So we have a motion and a second. Any further discussion? Anyone opposed? I like that better, by the way. Okay, it has passed. Thank you, sir.
Thank you.
I think we are done with you now.
No, we're not,
Oh,
we're not
whoa,
done
whoa,
yet.
whoa,
We're not
whoa.
done. So while you bring this subject up, you mentioned the cost and associated with the short expiration date, if you will. The members of the committee and some of the public folks have talked about support in potentially extending that expiration date, if you will. And so I don't know if there's additional discussion from the committee about being willing to do that, as we talk about with cyanokit and hydroxycobalamin.
We discussed that previously when we had so many drug shortages. The state rule is that you can't. The state rule is you're not supposed to have expired medications. Let me see if I do this right. If there is a good medical reason or due to shortages, I believe you can maintain that because it's better than not having the medicine. If it's just a cost issue, I do not think the state would support that. Is that correct? Yeah. I mean, you can't ask the state to break their rules, and the rule is a rule. So if there was a shortage, the state has said they understand that.
Well, the state says that they will take that into consideration.
Right.
They're citing you for violating the law,
Right. Right, but
or rule, I'm sorry.
yes, you would have to ask them to change their rule about expired medication.
There's a difference between marking it as a deficiency on an inspection and citing you with a violation.
Okay. Is there a shortage of this medicine, or is it just, nope? Okay.
It's apparently been used in Europe extensively for many years.
It's fine.
Yeah, the cost is considerably different.
Yeah.
We're gonna go there again.
I mean, I'm all for the education piece, but now we're putting this out and saying agencies should have it in $500 a pop or more. That becomes a.
Well, I think examples of what Dr. Purse has done in Houston with disseminating it regionally and not on every unit, and possibly, I know in some of the agencies I've worked in the past, that the ambulances or supervisors don't carry it, but actually the fire battalion chiefs carry it, and then we have a protocol that the paramedics can administer it.
Once they get
Yeah.
And that's
We
the
did,
approach
we
we're
did not
trying to
recommend
do.
that it be carried. We recommended dissemination of the information. We're not epiauto injectors.
Yeah, gotten there, yeah, but just for information, the cyano kits are also a potential antidote for hydrogen sulfide as well. So those people are in the fracking environments and worlds out there as another potential option, although not FDA. I would consider you becoming aware of that as well.
Does anyone have any idea when it comes off of patent?
10 years, isn't it? Well, it's been 4
But
or
from
5. I
when?
think it's another 5 years.
Okay. All right. Sam Vance, where'd you go? There he is. Okay, sorry. This is item number 4, agenda item 4, Pediatric EMS Recognition Program. I do not see Dr. Macias. Is he here?
After 2011.
2011.
Good afternoon. I'm Sam Vance. I'm the EMS for Children Program Manager. So the EMS for Children Advisory Committee has created a work group to develop a voluntary pediatric EMS recognition program, which is essentially a multi-phase quality improvement program for EMS agencies that want to basically improve their capabilities to take care of kids. It consists of 3 levels, a bronze, silver, and gold level. The bronze level would be consisting of carrying pediatric equipment based on the 2014 Joint Policy Statement of Equipment on Ground Ambulances and having current pediatric protocols, as well as having online and offline medical control for pediatrics. The silver level would consist of continuing education requirements for pediatrics that goes above and beyond what the state requires. And then the gold level would consist of the department providing community outreach, mainly on injury prevention type activities, things such as car seat safety installation, helmet safety checks, providing public infant and child CPR. The bronze level, which is the equipment level, that would be accomplished on an honor system, where since we have so many departments within the state, we can't possibly get around to check all of them. So again, it would be on an honor system where the department would have an affidavit that they would sign and have notarized stating we carry this equipment on 5 out of 5 ambulances, or however many ambulances that department has. The higher levels would consist of an actual survey by a person going out and checking the paperwork for the continuing education and looking at the community outreach. We would do that at the RAC level. We have presented this to the RACs, and I already have several volunteers from several of the different RACs, as well as a couple of the children's hospitals that are willing to go out and do those surveys. Additionally, we have presented this to not only the pediatrics committee, but the EMS committee and the RAC chairs, and have received very favorable comments from all of them, including Justin Boyd from RAC A has volunteered his RAC to pilot the program. Yesterday, I presented this to the Air Medical Committee for their review and their comments, as well as asking them to develop an equipment list for the air ambulances, because obviously they cannot carry the same amount of equipment as the ground ambulances can. So they developed a work group to put that together for us, and will be getting back with me on that at the February GETAC meeting. So I would like to present this to the Medical Directors Committee for your review and your feedback on this document before we kind of go live with it. And I will email that to either Dr. Beeson, Dr. Greenberg, or I can email it to the entire group. Okay, I'll email it to Dr. Beeson, and if you would be so kind as to disseminate it to the rest of the committee, I would appreciate it. Are there any questions?
Are you going to present that to council?
I was planning on doing that once I got all the feedback and we had a final document to present.
We probably need, how long would the presentation take?
Probably about as long as this did, 5-10 minutes tops.
Would the committee like to consider that for our next meeting? I think we actually need to see the presentation as a committee and discuss it. Yeah.
I mean, essentially, this is the, without seeing the document, I mean, I can just present the document to you and go through page by page if you'd like.
Well, I think we truly need to have it presented into
Okay.
not just the concept, but the devil's going to be in the details of this, because you're going to get a gut reaction from a number of us when you start talking about pediatric equipment on ambulances.
Sure. Again, it's voluntary. It's not a requirement. It's not mandatory.
Medicare.
I'm sorry.
So is Medicare. We know that. It's voluntary.
I realize that.
So I think we need a formal presentation
Sure.
for the committee to chew on. Or, the committee can override me on that. I'm more than happy. But does anyone, you want to?
We'll disseminate the document, and we'll put time on the next committee meeting, and we'll get with you whether we actually need a formal presentation. Definitely plan for some discussion based upon the dissemination of the actual document.
Could we have a small, maybe work group that reviews this document to be able to present it to the committee at the next meeting?
That'd be fine.
You're going to lead that, right?
Sure.
All right. So we need a bigger work group than one person.
I'd be happy to help.
Okay. Dr. Spear, Remick, and?
I'll help.
Excellent.
All right.
If you can, actually, if you can send it, if you can send it to the whole committee,
I can do that.
that would be good. The problem is, of course, we can't discuss by email.
Sure.
That would, it puts us all in jail, and we don't like that. Been there, done that. So,
Don't want to do
all
it
right.
again.
Any other questions for Mr. Vance? Okay, so we will look forward to that, and we will have it again on our agenda next meeting in February.
All right. Great. Thank you.
All right. Dr. Beeson.
Yeah.
Item number 9 on the Trauma System Committee Registry Work Group.
They had a meeting today, and I didn't make it because I was finishing up a talk. Is anybody in the room there? I know that the data's coming in. They're getting out of information out of the database. One of the racks is kind of becoming the initial, I wouldn't say test point, but at the point to where they're working with it. My understanding is that it's working well. I think some of the issues they're still trying to work is merging stuff. So EMS, if I put something in, can I get outcome from the trauma hospitals when they put stuff in? And that has not been fixed yet, but both are agreeing they'd like it to happen. So that's about all I have on there. Unless somebody in the room knows more than I do. Is that right, Brett? Sounds good. Yeah.
You're apparently the smartest guy in the room.
We're in trouble. Okay.
Did you have something? No? Okay. All right. I'll bring our attention back to item number 2, which is the policy you should have hopefully before you. There was discussion at prior committee meetings and the council, and it is on the council agenda for tomorrow to discuss the communication between EMS providers and receiving facilities. A work group was going to get set up. I don't think it ever did. We started talking about it then as happenstance. Policy statement came out in, I think it was July. It came out in the Emergency Nurses Association Journal, or at least this is what it's from, but it was a combination of ACEP, ENA, NAEMSP, NAEMT, and NASEMSO, the state officials. I'm not going to read through it. I hope everyone has had an opportunity to look at it. The simple question is, do we want to consider endorsing this, or do we want to come up with something else? And if we want to consider endorsing this, then we need to discuss it to make sure we're comfortable with that.
I'd say we can consider endorsing it. I think it looks like a pretty comprehensive way of handling these things.
Okay. So the item before us then is consideration of endorsement of this policy statement, transfer of patient care between EMS providers and receiving facilities. The way I would see this happening is we would take it from this committee to council, and at council we would say this is what we think works. The other committees, or actually the other council members, would have an opportunity to say yeah, or we want our own thing. So
The only issue I'm aware of, the concepts of the transfer of care and what should be done is in there. How that get done is not. I know certain RACs are working on report protocols, this and that, and my concern is that there's going to be some inconsistencies between RACs, and for those of us who work in multiple RACs, that makes a very difficult thing. So I know it doesn't have to do with this committee, but the overall concepts that are covered in that's what's required and what should be done, focusing on patient safety and the transfer of patient care, it's very good and very thorough.
And it gives lots of options on how the transfer happens, which is, one size fits all is not going to work for this. It's got to be local driven.
So I make the motion that we support this paper.
I second.
okay, motion and a second. Further discussion? That end of the table is being real quiet. So.
Well, I was pointing out my iPhone is very small. So I was taking a look at it, and the big concern I have is the time. So how much time do we have to get a complete record to the facility? Because I don't think in some facilities, some systems, it's reasonable to expect the complete document done at the turnover of care, because the resource, that ambulance, is then no longer available. I did just find where it said that it's within a clinically relevant period of time, so it doesn't specify, and once I saw that, I was happy. That's the reason I was being quiet.
I think that the actual thing it talks about, the patient at time of transfer, is the minimal key information that is required upon patient transfer, not the entire record.
I think it's
Entire records due within, what, 1 business day, is that what?
But that's not, it's not discussed in this paper.
Yeah, it's
Yeah,
not.
we had that last meeting.
In a timely manner.
The last bullet point in the paper is what I was looking at, and that talks about the entire document, but that says the clinically relevant period of time. So it's not, I'm happy with the wiggle room there.
Current state rule is 1 day, is that correct?
I think it's actually says 24 hours.
24 hours, okay. So again, but our job as a council and a committee is to advise the state about rules. So if we thought that the words clinically relevant were better than 24 hours, that would be.
In the other committees, the biggest discussion is certain hospitals and certain ambulance services are having trouble making sure the complete patient care record gets there and stays with the patient as it moves through their hospital system.
Right. Yes, sir.
Just for the committee's awareness, we have been discussing this in the EMS committee.
Can you identify yourself, please, sir?
Taylor George from Children's Health System in Texas. So at the EMS committee, we have been discussing this. At NICTRAC, North Central Texas RAC, we do have a specific work group that's been focusing on this. Jennifer Gardner back here is the lead on that. We have 44 different agencies providing input to provide guidance and recommendations to the state for clarification of Texas Administrative Code that specifically outlines the requirements for written documentation on patient care transfers.
Is there anything in what you're recommending that's different than this, or have you seen this?
Yes, that's actually part of support that we're using for this
Okay.
committee to move forward, and we are integrating into the current TAC 15711 requires at time of patient transfer, unless operationally otherwise unfeasible, that a written patient care report be given with specific indicators outlined on there. There's 10 of them, so otherwise a short sheet, and then a full patient care report be provided within 1 business day. So we're seeking clarification on either should it be 1 business day or should it be 24 hours specifically stated in the report, and what suffices from the state's point of view as a written patient care report. Can an electronic PCR submitted to a data hub or the hospital specifically fulfill that requirement, or does it have to be a piece of paper left at the bedside? So we've asked in the EMS committee that the state provide a position statement on that or specific guidance on what meets that requirement. A lot of the issues we've run into is the current technological state, different vendors, proprietary systems, et cetera, cost, expense built into all that as well.
Okay. Thank you, sir.
Did I miss anything, Jennifer? She was in here a second ago. I guess she stepped out.
Saw you stand up and she ran. Yeah. All right, so we have a motion and a second on the floor. Any further discussion? All in favor say aye.
Aye.
Anyone opposed?
I know I changed it. I'm trying to see if they're awake.
All right, so we will forward that on to the council. It is on the agenda for tomorrow, so the council should be able to consider it. And I don't know if it will go back out to the other committees because this was on some of the other committees' agendas, or if it'll just be adopted. Is Dr. Macias in here? I didn't see him either. Sam Vance, do you know anything about the pediatric transfer and transport guidelines? You don't have to if you know. If you do, that's fine.
I know the Pediatrics Committee has a work group that was headed up by Sally Snow to develop inter-facility transfer guidelines for pediatrics. I believe they have that draft document completed, and they're just wanting to present that to all of the different committees of GETAC for your input before they move on to the council with it.
Okay, so that'll probably be February as well?
I would assume, since Dr. Macias is not here.
Okay.
Sam, do you know if it was approved through the PEDS committee, the final document?
Yes, the pediatric committee did approve it.
They do.
Yes.
Do you have knowledge of it, Dr. Remmel?
I do. I helped Sally Snow with the transfer guidelines, but I know that we were waiting for final approval, so I don't have it to present. So
okay.
We can certainly wait until February if Dr. Macias is not here.
Okay. Could we also put you down just in case he's not here next time too?
Sure. Yeah,
just
sure.
That way we can get it. That way Dr. Beeson can get it completed during the meeting. Dudley, wait. He's not here, is he?
Really?
I don't see Eric either. Are we in the right place?
They're probably over at the National Campus.
Ah. Well, that's why. That's why the meeting's going so well. Oh, did I say that out loud? I'm so sorry. Anyway. So Dudley's not here. Dr. Troutman, I had a leftover agenda item. We're going to go back through some of the other items that have been on here for a while. Item number 19, Dr. Troutman asked that we discuss CPR training requirement for a Texas driver's license.
Yeah, so I think we, at this committee, or hopefully we would all agree that early CPR saves lives. And, you know, as we can try to get our first responders on scene, get our ambulances and medics and EMTs there to try to get that hands-only chest compressions, how can we get more of our public educated? Now, I think it'd be a really long goal to try to ever get the Texas legislature to make a mandate where everybody with a driver's license has to have some kind of CPR card. But I didn't know if anybody had ideas or maybe just kind of beginning talks on how we ever could move to that. You know, I know Texas, they do teach that like in the high school or public education level, that is a requirement. But again, you get that when you're 16 or 15 years old and you never have to renew. We know Seattle does have that as a requirement for a driver's license, and they have really good clinical outcomes with cardiac arrest patients. I don't know if there's any comments. I don't necessarily have any ideas on how to get that completed other than starting the process of trying to get TMA, TCEP, and other organizations behind something like that, and then finding legislatures.
A lot of us used high school health training or health course requirement that existed for high school graduates in Texas, but that was actually taken away now as optional. So we don't even have that as a mandate anymore.
I know in Austin we're looking into trying to make that a requirement. For driver's license.
I would say at a minimum that that sounds like a pretty good position statement. So that we can at least say, let it be known that the committee, and I would assume that GETAC would support that as well, I would hope, supports it and move that up as a recommendation to DISHUS and to the legislature. And then we could do the same thing with TMA.
Do we want to, just thinking about how we would get this pushed, do we want to specifically do it to a driver's license, or do we want to make it more vague and support universal CPR training and let somebody else figure out
The reason I like
how-
the driver's license is that it provides a very specific incentive for obtaining CPR. You know, everybody wants a driver's license, and so it's a great way to really enforce it. I worry that a more general approach to just everybody should get CPR may not really entice people to do so.
And the nice thing about the driver's license is it's renewable. It has to be renewed. So the understanding would be we would want the CPR to be renewed.
Yeah, I think some of the big downsides that I've thought about and just talked to some other folks is one is cost. You know, whose system, is this just an AHA thing? Is it the various other ones do we have? Is there some kind of system at the driver's license office you have to demonstrate and then you get the check off box? And then also, you know, we all know people that maybe are 80 years old and they can very appropriately operate an automobile, but if they got down on their hands and knees, they can't get back up, let alone doing CPR on somebody. So, you know, where do you, so it's like somebody like Dr. Greenberg may have that problem.
Well played. Well played.
I am not even the oldest guy.
The good news is he doesn't have to bend over to reach the patient. I know, I should have
quit.
So all those issues may be beyond the scope of what we need to do,
Yeah.
but just thinking out.
Okay, so the issue too of, is it just to initially get a driver's license, or is it to?
No, I think it'd be
renew?
ongoing.
I think it should be renewable, and the criteria for what constitutes the training should be as broad as possible. Honestly, I think we've made CPR training far too complicated. So as long as it involves hands and a chest and doing something with calling 911, I think I'd be pretty happy with that.
Here
Okay.
we go.
So we can, so again, we'll need to forward to GTAC our recommendation.
So our recommendation would be for Texas to support CPR training with driver's license renewals.
Is this something DSHS even have any
I think
input
they
to
should.
this?
No, I think, Jared, I think what we need to do is get
More
the
positions.
TMA
Right.
and the Texas Nurse Association. I think that more trade groups to get legislation and lobbyists to do something like that.
Right.
And more of this.
I think we'd have to partner with DPS, obviously.
Who are you, sir?
Forgive me. Adam Burke with Texas Health Dallas Presbyterian Hospital.
Thank you.
I'm the EMS liaison. What about printing the current CPR guidelines on the backs of driver's license so that everybody has it now?
Okay. Trying to think of a
Yeah, I think just a position statement.
yeah, we're on to a good idea. I'm trying to figure out how to push it forward. That's, you know, that could be part of it.
I think it's more GTEC says this is a good idea, and then I agree we need TMA and ENA and whatever organizations.
You are?
I'm David Wampler, UT Health Science Center, San Antonio.
Dr. who?
David Wampler.
Dr. Wampler, okay.
No, this is David Wampler, UT Health Science Center. Last legislative session, there was a bill that was passed that required all high school students to have CPR training prior to exiting and graduating from high school. So that could be actually used as a really nice template to be able to tack onto it. It was very, very general. They did not have to get any type of certification of CPR. They only had to have CPR training.
And that, you said that did pass?
Yes, that is currently in law. The one limitation to that, it's sort of this unfunded mandate. So now all of the school districts are trying to figure out how to implement it. This may be another one of the unintended consequences of the thing, but at least for the district that I sit on the committee to try to figure out the implementation of this. I've hooked our schools up with our local freestanding ED who's more than happy to have community involvement, and to our EMS system that is happy to have community involvement as well.
So that would cover Lubbock, where everybody stays there, but Austin, where everybody's from out of town, would still not have everybody doing CPR. So, is that
True.
correct? I mean, we're a state with a great influx of population.
Right.
And so even if you required it of graduating high school students, it would not, I'm not sure it would do what you want.
And it's not ongoing.
No, I agree. And I think tacking on to driver's license renewal is still a good mechanism to do that. But just follow sort of the guidelines that the legislation has already been passed.
All right. So I don't know that we need to spend a lot of time on this, because unfortunately we don't have power. We don't have an audience to send this to within DSHS. So they don't have overview of the driver's license. They've heard our concerns, so if DPS comes and asks them, they would tell them.
Your TTAF partner can take your position paper and talk about it.
Hi, Linda Dickerson, public member for GETAC. Wonderful idea. Only problem is, some of us are very old, and we would have to get an exemption. A lot of people. Plus, who's going to teach it? I used to be in a position that for my renewal of my license, I had to have a CPR card. And it was amazing how hard sometimes it was to find that. If you have every person that needs to renew their driver's license needs that CPR card, you're going to also, might be a money maker for the fire departments. But it's got some problems. I love it. I personally don't want anybody doing CPR on me because I'm too old, too brittle. But it's just one of those things that I think it's a great idea. I think it's got a lot of questions as well.
So I think you bring up a really good point, which goes to how proprietary the training is. And I think that's classically, when I said that I think we've made it too complicated, that's exactly the problem. So I think if you do this, it needs to be a very general body of knowledge as opposed to tied to a specific training course, and as opposed to tied to a specific card. It shouldn't be about the card, it should be about the knowledge. And quite honestly, I think if we just stuck with the didactic knowledge and didn't even require skills for it, I think we'd be a whole lot better off than we are now. So in order to renew, you actually just take a brief course. Really, Austin has a great program where they're teaching it in 10 minutes. And that includes the psychomotor part. So I think if we just did the didactic part, call 911 and press on the chest until someone gets there. And by the way, would recommend you go take a real course. I think we'd be light years ahead of where we are now. So I think that's a very good point.
Thank you.
I've been asked by the chair to poll the committee to see if how many people can pull out their CPR card right now and demonstrate their certification. So no, in light of that, so I think the strategy from the committee would be perhaps better served if we broaden this to that we are supportive of universal CPR training with perhaps initial and ongoing training, and perhaps develop a a la carte menu instead of just specifically limiting this to driver's license or attaching it to driver's license. I think there are lots of strategies that are out there. We would be supportive of probably all of those of enhancing universal CPR training, and then let perhaps those other organizations and supportive organizations like TTAF and some of the other folks provide the specifics and how to move forward with it. That would be acceptable as you're developing a motion for this. So.
Now, Jared, what I would say that DISHS probably can, and still doesn't exist today, is that every provider shows some evidence of pre-arrival instructions. Because I can tell you, if you've heard the videos that somebody activates the emergency system, they're asking for instructions on how to give 911, and that person entering an emergency call can't do it. So
right.
That would be something. I realize there's difficulties that not all providers answer and not all do emergency, but that would be something that DISHS. Brett's slowly shaking.
So just to move, did you have something on this, sir? Hey, come on forward. And just to move this forward, I'm going to put in my report to GETAC that this committee endorses the concept of universal CPR training Devil's going to be in the details, and we'll continue to work on it. Go ahead, sir.
I just wanted to voice support for Dr. Jarvis's suggestion there, and then one idea if you decide to move forward in the future for tying this to driver's license renewal for the DPS offices is maybe look at utilizing the pilot programs for the CPR kiosks that's in DFW right now, placing that into the driver's license office where you just simply demonstrate proficiency for your car, not necessarily getting a certification card.
All right, thank you, sir. Any other discussion on this item? I'm going to turn now to Dr. Malone. She had 2 items submitted previously, items 17 and 18. I'll ask her which she would like to take them, what order she would like to take them in.
I usually do talk pretty loud without a microphone. I didn't know it was going to be that powerful. Yeah, really what I'd like to talk about is 17, which has to do with, I would like to ask the committee to entertain that we develop a working group to start putting forward what we believe are key pieces of training that are needed in any concept of mobile integrated healthcare provider, community health paramedic, advanced practice paramedic, whatever you want to call it. It's not critical care paramedicine, and it's not expanded scope, but it's the critical thinking pieces that are going to allow paramedics to operate in the field with physicians who are supervising that more direct care. So I'd like to request, could we broaden what we believe these needs are? I'm sure Dr. Beeson has a lot of information about that already, as well as Dr. Jarvis and the rest of you. But I mean, they're asking all of us. It's now being discussed in the Education Committee, which unfortunately, I was in the NIMSI class, instructor class, and I was late and I didn't get to attend that meeting. I apologize. But I'd like for us to at least to begin to look into what those requirements should really be.
I think the 2 points in that committee were that, number one, it's about 200 hours. And the other one is that it's very community specific. And so what you train to has got to be to what your community needs. So doing a universal program would be nice, but there are a lot of these programs out in far rural West Texas that.
Well, that's true, but I think there's, what I was really thinking is that I'm thinking about the basic pathophysiology. What are these core concepts? Because we all know CHF is one of the most recurrent things out there. So what do we have some advice that we would hand to individuals trying to create a training program as far as what those key pieces would be? Diabetes, congestive heart failure, cardiac disease in general, COPD, COPD itself. So that's what I'm talking about. At a high level, what would we recommend to people that want to do this training? What do these individuals need to know to assist them in making those assessments and then communicating that assessment to the physician? I mean, just as an example, physician speak is a very big one. They need to be able to talk to us in our own terms. So there are key pieces like that which would still have to be regionalized, but there are core medical concepts, and that's where I was headed.
I agree with Dr. Malone. There are states that have great examples of endorsements, or they call it, where they're not certified, but there are criteria set up to get an endorsement from the state to even be to call yourself a critical care paramedic or to call yourself a community paramedic or whatever it may be. And I think that we fall pretty short in the state on those things, because we all know that there's really no recommendation or requirements to call yourself critical care paramedic. If you I guess you could watch a YouTube video and call yourself that if you wanted to. But I think this concept needs to go farther than just the community paramedic piece. I think it's something that we need to look at a state level, making recommendations to DSHs to try to fix recognition of these other endorsements that we do in EMS.
So I would maybe perhaps entertain a motion that we forward to GETAC a recommendation to develop a work group or task force with the multiple committees involved with this to help identify our way forward with mobile integrated health and community paramedicine.
Do you want to do that first, or do you want this committee to work ahead of time.
I think right now there are so many, Jeff alluded to, so many states that are doing it on the national level that it's being discussed, and if we have the tolerance, the question is, do we have the tolerance to wait till those national recommendations come out, or do we kind of go it alone? I think that developing and having discussions in our own, but I think it should be a multidisciplinary approach to it as we look at it here.
So I second the motion, we'll have discussion.
Okay.
So-
Discussion, and we have a person from the public that wants to.
Go ahead, Mr. Public.
Discuss first.
Go ahead, Mr. Public.
Come on, Mr. Public, we want to hear.
It's Dr. Public.
Dr. Public, go ahead.
Dr. John Q. Public. No, Taylor Ratcliffe Baylor, Scott and White. So, Dr. Malone, you echoed exactly, I think, what everyone else understands is critical to happen. This has to happen, and I think Texas, by our nature, we would like to independently guide us forward in the proper fashion before it is dictated to us from a national level what we want to do. So, representing the Education Committee, I don't see Jody. Okay, all right. This has been, actually, I want to say, since the Education Committee has successfully deleted all of our other action items since we've done such great work, this is all we're left with. Just kidding. So we have repeatedly had on the agenda this exact issue. And so there's been much discussion, and we've had several breakout sessions in groups already, and not violating open meetings rules, but independent research, let's call it, into what we would like this to look like. And the idea behind this that Jody's really driving is that we would try from the education side to bring to this group, to the council, and obviously to the medical directors group, recommendations on what we think this base training should look like, notwithstanding the fact that there will be considerable variation, considerable financial cost, and everything else. And my voice to the matter is, I think we're going to have to come up with a plan where we do have a route of funding or some kind of recuperation of cost for an employer to be willing to send their paramedic or whoever, it doesn't have to be a paramedic, whomever they wish, to go to this training, 200 hours or whatever it is. There's going to be a substantial cost to the employer. So actually, I would like the medical directors group to look into how they feel about moving forward with legislation and other things to try and start vetting out how we can come up with clear, concise repayment methods, a model that we can recreate, whether it's the MedStar model or somebody else who's functioning and recuperating costs. And we've had discussions. Some of the money is tangible money, and some of the money is recovered expense that never was budgeted. Yeah, funny money, right? So I would encourage the two committees to work closely together. The Education Committee has time and time again said that it will be dependent on what the medical director for that agency decides will be the scope of practice for that advanced practice professional, regardless of what we train them to. So if y'all would like a report on that, I'm sure we can provide one next time.
I appreciate that, Dr. Ratcliffe, because I truly believe that, this is going to happen with us or without us. And so if it isn't driven by us as the Medical Directors Committee for GETAC, if we don't have an opinion about what the floor should look like, and realizing that it's going to be adjustable for any circumstance, but we need to have a concept about what this actually is we're doing.
Would it then be helpful for a couple of our members to go to that December meeting or January, the meeting when the Education Committee is going to?
Yes, sir. Yeah, January 16th.
January 16th.
It's going to be in Waco at MCC at, I think, 9. That was announced today.
So we probably ought to have a couple of representatives there. Or would that be permissible? Would they allow?
I think the chair would completely agree with that. Yeah, I think he would enjoy that. It's an open meeting. Yeah. And then we need to be doing a better job, I think, about giving you some reports on where we are with that process. So,
once again, for my discussion on the motion, I think that it's great to come up with educational standards on the floor, but the problem is there's nothing to require people to do this or go through this training or have any endorsement today. There's no process for that. So you can set the floor, you can make recommendations, you can have people go through this, but there's nothing to prevent somebody else from saying they're the exact same thing without having any training other than a YouTube video. So, and I'm not proprietary to YouTube, you can watch anything you want. But my point is that we need to work with dishes to develop some process of endorsement for things such as critical care, such as community care medicine, such as other things. Because right now,
if I'm not mistaken, I think that's one of the things that we're planning on doing in January is to develop not only the structure of that training, but also how to have a rule.
Yes.
That is the goal. I mean, remember, the
Good.
goal of GETAC is to advise the state about rules.
Yes.
So,
Okay.
We're afraid this will be a huge elephant many years in the eating. So,
Yes.
So Jeff, what?
that is the goal.
so we have a motion and a second and a call for a task force. Dr. Malone, I'm assuming you would like to be on said task force.
I would be delighted.
Who else would like to be on said task force?
I will. That's twice.
What was that date again?
Wow.
16?
Bradley? Beason? Did I hear you say this?
Yes.
All right, that's 4, that's plenty. All right, Doctors Malone, Jarvis, Bradley, and Beeson. You will report back next meeting, which will be after the January 16th meeting in Waco. Hopefully somebody can go. It's Friday, 9 o'clock, Waco. At MCC, yes, at McLennan County College, community, sorry. All right. Did you want to talk about, we have 4 minutes. Did you want to talk about Narcan?
You know, I think we should probably just delay that and.
Okay. Oh, we didn't take an official, but is anybody opposed to that work group and working with the education committee, et cetera? Okay, that's unanimous then. We have 3 minutes and 45 seconds. Are there any of the other remaining agenda items besides the one that starts with an E and has to do with a virus that anybody would like to talk about?
How about your number 12?
There's a virus.
Number 12.
There's an e-virus?
Yeah, I haven't had a chance to do
You
anything.
can only get it on your computer, Jeff.
There's a great article about Raleigh doing a new way to take care of behavioral health patients in which they avoid pulling into the ERs altogether with a process of taking them to site. Some of them are not full inpatient site, but they're intermediate site facilities, and they're avoiding most of the patients going to the ER.
Yeah.
I think we ought to look at it.
Yeah, the Bell County, which is where I live, just started up a crisis intervention team run by the Sheriff's Department. Their primary job is to divert behavioral health, people with behavioral health disorders from the jail. That does mean they actually bring a few more to the emergency department, but it does streamline their care. It's not bad. It has actually sped things up. So if you have CIT programs, crisis intervention team programs in your area, I think it is very important we support those. So, Dr.
Number
Spear.
10, on number 10, the long spine board, C-spine clearance.
Yes.
The main thing to report is, in my practice, is wow, this has come a long way. I'm seeing patients arrive without long spine boards, nurses and staff not complaining, no neurosurgeons are unhappy. You know, Dr. Manifold said it's going to take 3 to 5 years for this culture change to occur, but in the first year or so, it's going better than expected.
I think it was honestly something everybody wanted to do anyway. Everybody was just scared.
I think so.
It's a Texas term, scared.
Dog would die is hard.
It's easier when you don't have to be the first one.
Yeah. Anything else from anyone else? Cardiac Care Committee is already trying to jump up here, which is good. We'll be done early. All right. It has been a pleasure to chair this committee. I appreciate it. It's been fun, and Dr. Beeson will have a lot more fun. We are adjourned. Thank you.
Thank you, Dr. Greenberg.
Thank you.